doing it again. So you guys discuss pulse wave and pinpoint and a lot of things. So we just want to give some flavor of debates in surgery. So practically we have two modalities today we will discuss, and my aim to convince you that the cryo is better than RF. So again, if you look at, this is one of the slides I used before. So I would just want to show you how does this evolve over years. So I will show you how does James Cook's do this operation. So bear with me because this is very complex. So he got the right atrium, and as you can see here, I'm not going to go in very detailed, but he chopped the appendage, he opened the right atrium, he cut into the right atrium, to the tricuspid annulus, then he opened the and then he used cryoablation to ablate, and then he saw everything together back, and then he opened the septum, accessed the left atrium, cut the all pulmonary veins, saw them back again, cut to the left atrial appendage, saw it back again. So there is a lot of cut and sewing. So describing this, as you can see here, there's a lot of cut and sew. So this makes it very complicated and very risky and very risk of bleeding. So surgeons did not adapt that. So that's why we developed energy sources that might develop the same lesion set without the cut and sew. And that's why we have the unipolar, the bipolar, laser, microwave, high intensity ultrasound, and cryothermia. So the radiofrequency, it is, we use the thermal injuries, and it has a current which range between 100 to 1,000 kilohertz. We can use a unipolar pen or bipolar clamp. Usually unipolar RF will heat the tissue up to 90 degrees, and this can be applied endo or epicardially. The RF clamp, this is it's like a clamp. It's a jaw. You put the tissue between the two jaws, and the energy goes between the two jaws. And here is the bipolar RF. Usually, it will heat the tissue up to 60 to 70 degrees Celsius, and this will need 20 to 30 seconds to have a transmural lesion. And the main limitation for that is that you have an injuries to the surrounding structures as coronaries and coronary arteries and valve tissue because of the denaturation of the collagen during the procedure. In the contrary, the cryothermia is actually cool the tissue down and will cause the injury by causing an intracellular and extracellular ice crystal formation. And in surgery, we use two kinds of gas. We use nitrous and we use argon. So in the nitrous, we cool the tissue up to minus 90 degrees. In argon, it reaches up to minus 180 degrees. So you have to keep in mind when you use a cryo, this depends on multiple issues. It's that the probe temperature, the tissue temperature, probe size, the duration, and what is the kind of gas you use. And usually, if I'm doing this, I use usually 3 minutes application on the left and 2 minutes or 1 minute application into the right side. So Ralph Damiano, he is one of the big names in the States, and he advocate to use RF procedure. So if you use an RF procedure, so practically, as you can see here, the white lines, this is the isolation in the left. As you can see here, we isolated the left and the right, and then we complete the box lesion by by doing the line from the jaw here and the jaw here. So practically, all this area of the left atrium is excluded. And then you continue to the left atrial appendage by chopping the appendage and going from the appendage to the left superior pulmonary vein, and then you saw that. And then you do the mitral annular lesion, which you connect from the lower border of your left atriotomy to the P3 area of the mitral valve. And this is when you call it a complete Cox-Maze left atrial site. So this is what we do. We take the jaw clamp and we do that onto the right side, onto the left side. And then we do that the same thing on the right side when you open the right atrium longitudinally, and we isolated the superior and inferior pulmonary vein. So if you imagine the left atrium, if you're going to do this with minimally invasive, which is mini thoracotomy, you have to imagine the left atrium as a surgeon. So we open the left atrium here, and we isolated the right by the jaw, and we do that, continue with the jaw lesion by the bipolar. The problem with using bipolar in minimally invasive operation, you cannot get a complete because you'll not be able to reach to the left because you're going from very small incision. That's why we use cryoablation just to continue the left side, and we use that for the coronary and the mitral lesion. Same goes for the right, because you open the right atrium into small incision here, and then you do the SVC, IVC, you do the tricuspid annulus lesion, and from the right atrial appendage you do the right atrial wall, and then you continue that with the cryoablation. So if you're going to use an RF in minimally invasive approach, it's not compelling because you have to combine both. So cost effectiveness, and also it became a very complex. If you do it sternotomy, which is easier, you can complete almost everything with RF cryo, because you'll be able to isolate left and right. You continue the box, you do the mitral annulus lesion. Having said that, you have to use the cryoablation. So again, even if you do sternotomy with RF ablation, you still have to use the cryo, and this is again not cost effective, and it takes also time. So I published a paper when I was in my training. I'm showing you here, and I will show that my technique in doing this, I use only single source, which is cryo, and I do that with 2 incisions only. 1 incision into the left atrium, 1 incision into the right atrium, and we'll be able to finish everything. So practically, we take the probe and we go from this side all the way to left atrial appendage, and then we take the probe and we do the J lesion side, and then we finish that with coronary sinus and the mitral annulus. So practically, if you look at this from electrophysiological perspective, all this area of the left atrium, it's excluded. So that's why I said BVI, because now the veins is already excluded, plus the left atrial appendage, which we all discussed about the extra line, and the coronary sinus and the mitral annular lesion. And why do we do the mitral annular lesion? Because we want to prevent the atypical atrial fibrillation, because it's happening in 10 to 15%. If we look at the right side, when we do the right atrial incision, we do SVC, IVC, and the modified right atrial appendage lesion and the tricuspid annulus. And this, if you look at the tricuspid valve, we do it between the posterior and anterior leaflet. So I'm not gonna, because again, data show that long-term outcome of Cox-Maze-4s, it is actually work, and it's there to stay. It has 66% freedom. And I showed that before. Experience of surgeon is very important to keep patient in sinus rhythm. So what is the available technology in market now? We have ArterCure, which is this kind of probe. We have 2 probes. We have the semi-flex and flexible. And in ArterCure, we used a nitrous, and that's why we cool the tissue to minus 60 degrees Celsius. The other available probe in the market is the Medtronic. We call it CryoAblate, CryoFlex. Medtronic, they use an argon gas, and they cool the tissue very low to minus 140. I have to say that Medtronic, it sometimes give you better lesion set, but the problem with Medtronic is that the probe does not defrost. So you have to wait for time, you have to give saline. And if you do minimally invasive operation, I don't prefer to use Medtronic. I use it all the time in the open cases, because it's you have room, you can work, you can give saline. But if you work through the small incision, you don't have a lot of room to move. So that's why I use ArterCure, because it has frost and defrost mechanism. So I'm going to show you the data in our center. This data, I'm sorry, it was not updated because I don't have time, but we reach up to 80 cases now. So we have 46 females, 54 males, and our mean age was 51 years old. So this is their baseline. And why I'm bringing this, because you can see here that most common presentation was heart failure, which is class 3. And you can see here that they have, some of them, they have previous stroke. And the most important thing that these patients are not selected. They have diabetes, they are hypertensive, and I don't really tend to select cases. So I do that for all kinds of surgeries: mitral, redo mitral, minimal invasive, mitral valve repair, and I do that with other procedure: tricuspid repair, tricuspid replacement, aortic valves, cabbages, and as you can see here, all the cases, they have left atrial appendage closure, because this is part of my procedure. Cox-Maze-4, I don't call it Cox-Maze-4 if I don't close the left atrial appendage. Why I bring this? Because I have the question in the morning: do you exclude patient with atrial dilatation? No. And I don't do that in purpose because I don't have patients. If I'm not doing them, I will not do patients because everybody comes to my OR with the left atrial dilatation. If I'm going to be picky and just do 4 and 5 centimeter atrium, I will not have patients. So that's why you could see that 70% of my patients, they have severely dilated left atrium. So I'm bringing you a real outcome. So do we have mortality? Yes, we have mortality. Do we have recurrent atrial fibrillation? Yes, we have 5.5 recurrent atrial fibrillation. Yes, we have some patients, they need a transfusion. But I have to tell you, if you look at, but most of them, they've been discharged home. Most of them, they are on anticoagulation, not because I'm doing MACE, because they have, as you can see here, most of them, they have mechanical, mitral, and bioprosthetic aortic valves. And that's the reason why they should be in anticoagulation. So doing Cox MACE 4, is it good for patient? Yes, it is good. Why? Because you look here at 18 months, we be able to put most of these patients, we started here, as you can see, in class 3, most of them now in class 1 and 2. So yes, they have a better heart failure symptoms. And what about the freedom from atrial fibrillation? Because that's the question. You're doing severely dilated left atria, rheumatic disease, and this is also the argument from my colleagues in cardiology. Why should we do them? Well, at 1 year, still the data to come. As I said, we follow them for 5 years. We have a 94% freedom from atrial fibrillation. And what about freedom from stroke? We have good freedom from stroke, which is up to 98.2%. And I have a case here, just if I have time. I don't know if I have time, but I'll show you how do we do that. We do that surgically. So I have a patient here with severe MR and with the atrial fibrillation. I'm just going to jump to the MACE part because I think people will be we're going to do that in the afternoon in real life. But okay, so here we open how did this do minimal invasive through this very small incision, as you can see here. So we use the probe. This is the first lesion, which is the coronary sinus lesion. We open the left atrium. We come from outside the heart where we see the coronary sinus. We put the probe and we start freeze from outside the heart. And then you will be able to see the crystal ball later on inside the left atrium, close to the P3 area. As you can see here, this is start to freeze now, as you can see. And I mark here because I want to know exactly where I'm going to do my mitral annular lesion, because this 2 lesion has to be a mirror image. So this is the first lesion from the left atrium when we go from the border from the left atrium, and we go to the left atrial appendage. And you can see here the pulmonary veins, which is the left, are down here and the right is down there. So this is the first line of isolating the left atrium. The other, which you call the J lesion, which comes from the upper border of the left atrium and goes all the way to connect the 2 lines. So practically, all the back wall of the left atrium now, it's isolated. And you ask me why we don't test, because we see this in our eyes. We know that the lines is connected and all the tissue we know the demarcation of the tissue, and we know that it's full thickness because we could look from inside and outside. We know that the lesion is going transmute. That's why surgery is because we can see. You guys depend on eyes so right atrium, I open the right atrium, very small incision, as you can see here. And then we start doing the mitral annulus lesion. Tricuspid annulus lesion. And this is going from the upper border. As you can see here, this is the anterior and this is the posterior tricuspid leaflet. While I'm doing this, I give plegia because you want to prevent right coronary artery injury. And we freeze here for, as you can see here, you see this, we know that the tissue now is transmural because it's already frozen tissue. So after we finish this lesion, we go to the SVC and we do that from the lower border of the right atrium, we go all the way to the SVC. Here you have to be cautious of 2 things. You have to be careful about the SA node because you can cause SA node dysfunction, and you have to be careful about the phrenic nerve because phrenic nerve comes in very close proximity to SVC, and you can have diaphragmatic issues. So I just want to show how we close the left atrial appendage, because we have the question today about that. Yes. So you can see here the left atrial appendage, we close it minimally invasively. We use a double layer technique when we close with, and the question about circumflex artery, that comes all the time. So you have to be careful when you do your bite. The circumflex artery lies 1 centimeter away from the annulus and 1 centimeter away from the left atrial appendage. And this is how does it look after we finish. See, it's double layer, nicely closure. When people do, and this is the continue of the video because I do mitral valve repair. Forget about that. So when you do that, if you do burst string, when you tie that, it would time it to a loose. But if you do a double layer, when you're sure that the first layer going a bit deep, the second layer is going superficial, and you do what you call imbrication technique, when you include the tissue of the left atrial appendage in your line of closure, the rate of recurrence is very low. Thank you so much for your time, and happy to take questions if we have time.
Thank you, Mohammed.